Hi, I'm Matthew, and today I will be reporting an upper and lower extremity prosthesis case report. So let's first tackle the upper extremity prosthesis case report, which is the three-dimensional printed upper limb prosthesis for a child with a traumatic amputation of the right wrist. So first, let's tackle the patient information and surgery. So the patient is an 8-year-old boy and was referred to the orthopedic department with a severe acute mangled injury of the right dominant hand immediately after a mincing machine accident. There was a severe deformity at the level of the right wrist, extensive soft tissue crush and detachment, and an open wrist fracture were noted. An comminuted fracture of the bones of his right wrist was diagnosed on the emergency radiographs with a mangled extremity severity score of 8. The first surgery that was performed was a wrist disarticulation, and then the second one, the patient received a repair of the amputation stump, again with the double pedicle advancement flap. At 4 weeks, after the second surgery, the wound healed successfully with the stitches removed. Now this picture shows the radiographic and macroscopic examination of the affected limb. Now let's move on to the prosthetic design. So the design of the prosthesis was based on an open source design, which is the Raptor Reloaded from the thingiverse.com and recustomized to fit the patient. The whole process includes measurement and scanning of the stump, customization, printing, and assembling of the components. The length and circumference of both an affected arm and the residual part of the affected arm were measured as a reference of the customization of the prosthesis. Components of the device include the distal phalanges, proximal phalanges, finger snap pins, knuckle pins, palm, gauntlet, hinge pins, and arm cap. The components were then assembled with the nylon string and the medical level foam. The control cable system allowed the distal phalanges to open with extension and to close with flexion of the elbow of the recipient. Now this picture shows the components of the 3D printed upper extremity prosthesis. So next, we move on to the prosthetic training and rehabilitation. So the personalized prosthetic training and rehabilitation program were applied after the installation of the device at 6 months after the second surgery. The program included a pre-prosthetic, interim, and post-prosthetic program. In the pre-prosthetic period, care was given to keep the normal range of motion and the strengthening of the amputated arm, shape the stump or for fitting of the prosthesis, and take care of the scar and edema. So after the fitting of the prosthesis, the amputee received the scheduled training for prosthetic control, repetitive drills, and activities of daily living or ADLs. The ADL training was performed according to the rating guide developed by Atkins titled Unilateral Upper Extremity Amputation Activities of Daily Living. The patient was asked to visit the outpatient physical therapist twice per week for the first 8 weeks, once per week for the next 4 weeks, and then once per month within the first year. And education of both recipient and parents was also provided, involving the loading, cleaning, and supervision of the prosthesis during activities of daily living. And finally, we move on to the outcomes. So, after a 3-month follow up with standardized rehabilitation, the child functioned satisfactorily in various ADLs, such as eating, writing, and self dressing and riding bicycles when utilizing the prosthesis. Some fingers and knuckles and cables were replaced twice due to the daily wear and tear, and both the recipient and parents did not report any special complications regarding the 3D printed prosthesis. So that is all for the upper extremity prosthesis case report. So now we will be moving on to the lower extremity prosthesis case report. So for the lower extremity prosthesis case report, I would be reporting the osseointegrated total knee replacement connected to a lower limb prosthesis. So first, let's tackle the patient information. Okay, let's start. So there are four patients. Three of them were men, and one of them was a woman, ages between 38 and 77 years old. One patient was wheelchair bound and presented with a short residuum of 3.8 centimeters. The other three patients presented with difficulty walking with their customized socket, even for the short distance, and they also had radiographic knee arthritis. These three patients suffered from socket interface problems that reduced their personal, recreational, and professional activity level. At post preoperative assessment, the three prosthetic users presented with normal posture, walked in an antalgic gait, and had skin breakdown at the distal end of their residuum. All patients complained of phantom limb sensation and pain, and stage 1 of the procedure for all four cases occurred between August 2012 and April 2014. Patient follow-up ranged from 12 to 32 months and 10 to 30 months after completion of stage 2. So now we move on to the surgical techniques. So, a two-stage surgical procedure was performed 4 to 6 weeks apart to connect an osteo-integrated tibial prosthesis to the cemented tibial base plate of the standard hinged TKR prosthesis, transferring the load directly to the femur and enabling the tibial residuum and the knee joint to act as the weight-bearing structures. So now we move on to the implant design. So the implant consists of four components. And the first one is the knee prosthesis, and the one used was a standard cemented stem rotating hinge knee system. The second component is the tibial osseo integrated implant and was made of titanium and plasma sprayed with a rough surface. The third one is the dual conus and was made from a cobalt chrome alloy coated with titanium niobium. And the fourth component is the cobalt chrome taper sleeve. And the tibial platform and the dual conus were secured to the osseo-integrated implant via a locking screw. For the post-op care, wound care involved daily dressing changes with dry ribbon gauze, and sutures were removed after 14 days. This was until the wound granulated over the titanium niobium oxide polished surface of the dual conus. Thereafter, the patients were instructed to wash the implant skin interface with warm tap water and soap and to pat it dry. So now we move on to the rehabilitation management. So all the patients followed a modified version of the osseointegration group of Australia Accelerated Protocol or the OGAAP for post-op care and rehabilitation, which integrated guidelines for TKR and osseointegration fixations. Patients mobilized without weight bearing using a forearm support and assisted by physiotherapists. Knee motion and core strengthening were also commenced on day 1. Following, the second stage of rehabilitation involved actual loading of 20 kilograms twice a day for 20 minutes, with an increment of 5 kilograms per day until reaching 50 kilograms or half of their body weight. Balance and gait training was commenced once the patients were fitted for the prosthesis. They were also allowed to mobilize with full weight bearing using two crutches for 6 weeks, followed by another 6-week period with a single crutch and unaided thereafter. So now we move on to the clinical outcome. So all the patients had a pain-free knee and no phantom limb sensation at the follow-up assessment. Case 1 reached maximum range of motion of 0 to 90 degrees, while the others had 0 to 110 degrees. The implants were stable and well aligned. See figure 4C on the next slide. All patients had complete healing with no discharge at the 3-month follow-up, and none of the cases presented with granulation tissue. See Figure 3 on the next slide. Only case 3 and had one episode of superficial infection and a broken bushing or an external abutment. So lastly is the functional outcome. So all cases improved in ambulation and activity levels, although no statistically significant difference was apparent. The improvement in daily number of steps ranged from 18% to 730%, and the improvement in duration of physical activity ranged from 18% to 550%. Case 3 remained at level K3 for mobility or the community ambulatory, while cases 1, 2, and 4 improved their ranking by 4, 2, and 2 levels after the procedure to reach the highest K level, which is the K4 or active adult. So that is all for my upper extremity and lower extremity prosthetic case report. Thank you for watching.